ज्यादातर तो रिहेबिलिटेशन पर फोकस होता है पोस्ट एक्सरसाइजेस, क्योंकि इनिशियली तो हमारे पास जो पेशेंट आते हैं उनमें ज्यादातर कंप्लेन यही होती है पेन की, जो कंसल्टेंट डिसाइड करता है कि हम एक्सरसाइज सर्जरी की तरफ नहीं जा रहे, हम रिहेबिलिटेशन और कुछ ट्रायल बेस्ड थेरेपी करना चाह रहे हैं, तो उसमें ज्यादातर हम मरीज को कुछ बेसिक्स एक्सरसाइजेस हैं वो टीच करते हैं और कुछ जनरल मेथड्स हैं वो टीच करते हैं। तो ज्यादा फोकसफुली वर्क मरीज खुद ही कर लेता है अपने घर। लेकिन जो रिकंस्ट्रक्ट के बाद कुछ प्रोटोकॉल्स हैं जनरली जो हम अपनी प्रैक्टिस में यूज करते हैं वो यहाँ पे डिस्कस करेंगे। तो हमारा जो एम होता है वो रिड्यूस द पेन होता है थ्रू दी मायोफैशियल रिलीज, और जो दूसरा एम है इम्प्रूव द मसल स्ट्रेंथ थ्रू द मसल एक्टिवेशन एक्सरसाइजेस, हम आगे डिस्कस करेंगे। रेंज ऑफ मोशन मोस्ट इंपॉर्टेंट, इसमें थेरापेटिक जनरेट एक्सरसाइजेस होती हैं। फंक्शनल एक्टिविटीज, जिसमें हम मरीज को कुछ ऐसी एक्सरसाइज इन्वॉल्व करवाते हैं जिसमें ग्रेविटी असिस्टेड एक्सरसाइजेज होती हैं, और नॉर्मल गेट पैटर्न, इसके ऊपर फुली फोकस हम होते हैं क्योंकि सर्जरी के बाद पेशेंट में फोबिया डेवलप हो जाता है और वो अपने एक्सेसरी मसल्स को यूज करता है अगेंस्ट द ग्रेविटी। जिस तरह के आप देखते होंगे कि किसी भी पोस्ट सर्जिकल पेशेंट होता है वो लिम्प करके वॉक कर रहा होता है, तो उसमें वो अपने ग्लूटियल रीजन और बैक के मसल्स को यूज करता है, क्योंकि आगे जाके फिर बैक की कॉम्प्लिकेशंस और इस तरीके से सेकेंडरी कॉम्प्लिकेशन में वो इन्वॉल्व हो जाता है। ये हमारे वीक वाइज कुछ प्रोटोकॉल्स हैं जो हम फॉलो करते हैं। जो फर्स्ट वीक में हम मैनुअल थेरेपी में सॉफ्ट टिश्यू मायोफैशियल रिलीज करते हैं, जिसमें पोस्टीरियर कंपार्टमेंट के मसल्स आते हैं, आईटीबी बैंड है, एडक्टर्स है, क्वाड्स है और काफ मसल है। एक्सरसाइजेज में हम एसएलआर देते हैं। एसएलआर जो है वो 20 डिग्री तक कांस्टेंट होनी चाहिए, क्योंकि 20 डिग्री एक एंगल है जिसमें हम स्पेसिफिकली क्वाड्स की एक्टिवेशन पे काम करते हैं। स्टैटिक ग्लूटियल सेट्स हैं, एंकल पंप्स हैं, और अपर बॉडी अर्गोमेट्री है। अपर बॉडी अर्गोमेट्री में हमारे पास एटीयू में थेरा रेजिस्टेड एक्सरसाइजेस के नाम से एक मशीन है जिसमें हम पेशेंट को इन्वॉल्व करते हैं, जिसमें मरीज की अपर लिम्ब यानी कि एक्सेसरी मसल्स के ऊपर फोकसफुली एक्सरसाइज करते हैं, जिसमें पेशेंट फोकसफुली हो, क्योंकि सर्जरी के बाद वो इतना फोबिक हुआ होता है कि वो अपनी एक्सरसाइजेस के प्रॉपरली कंसंट्रेट नहीं कर पाता। तो हम उस फोबिया को ब्रेक करने के लिए उसको कुछ एक्सेसरी मसल्स की एक्सरसाइज करवाते हैं, जिसमें ये अपर लिम्ब अर्गोमेट्री बड़ा इफेक्टिव रिजल्ट है इसका, और दुनिया भर में इसमें काम हो रहा है। और फॉर पैसिव रेंज के लिए हम बेड पे मरीज की हैंगिंग डैंगलिंग करवाते हैं विद ग्रेविटी असिस्टेड और फ्लेक्शन पर्पस। गोल्स हमारे क्या होते हैं इनिशियल फर्स्ट वीक में कि हमने पेन और एडिमा रिड्यूस करना है, और 70 डिग्री एटलीस्ट हम अपनी रेंज ऑफ मोशन अचीव कर लें। वेट बेयरिंग जो है वो पार्शियल हो, लेस देन 50 डिग्री, इसका भी एक प्रोसेस है, हम पेशेंट को एजुकेट करते हैं। और जो उसका ब्रेस एम्बुलेशन के दौरान वो ब्रेस यूज करता है, जिसमें एक्सटेंशन लॉक होती है और गेट के क्रचेस के थ्रू वो अपना गेट साइकिल और अपनी नॉर्मल एम्बुलेशन करता है। वीक 2 और 4 में कंटिन्यूसली वही सॉफ्ट टिश्यू मायोफैशियल रिलीज होते हैं, जिसमें आईटीपी, एडक्टर्स और क्वाड्स एंड काफ और पोस्टीरियर हैमस्ट्रिंग रूट मसल हैं। और कंटिन्यू हम करते हैं प्रीवियस जो हमने एसएलआर, स्टैटिक ग्लूटियल, सब प्रीवियस एक्सरसाइज में। और ये मोस्ट इंपॉर्टेंट चीज है मैनुअल रेजिस्टेड एक्सरसाइज, जिसको हम पीएनएफ कहते हैं। पीएनएफ स्टैंड्स फॉर प्रोप्रियोसेप्शन न्यूरोमस्कुलर फैसिलिटेशन एक्सरसाइज होती है। ये थ्रू दी थेरेपिस्ट होती है, जिसमें हम एंकल और हिप के ऊपर कुछ मैनुअल रेजिस्टेंस देते हैं अकॉर्डिंग टू पेशेंट, जिसमें वो प्रोप्रियोसेप्शन डेवलप करता है। ये बहुत जरूरी होती है पेशेंट की आफ्टर दी सर्जरी। ट्रंक स्टेबिलिटी एक्सरसाइजेस, 3 लिम्ब प्लैंक्स के ऊपर फोकसफुल होते हैं, बैलेंसिंग एक्सरसाइजेस करवाते हैं, एरोबिक एक्सरसाइजेस हैं जिसमें हम ये खास किस्म की साइकिल यूज करते हैं जो कि हमारे पास एक टीम में है। इस साइकिल में ये होता है कि इस पेशेंट जो है साइकिल के साथ साथ विद अपर लिम्ब, जैसे कि इलेप्टिकल आपने देखा होगा, इलेप्टिकल में तो पेशेंट स्टैंडिंग पोस्चर में होता है, लेकिन यहाँ पर थोड़ा सा वेट बेयरिंग का इशू होता है, तो मरीज कॉन्सेंट्रेटली एक्सरसाइज फोकस नहीं होता। तो इसमें हमने एक सैडल सीट लगाई हुई है जिसपे वो अपना वेट बैठ कर अपनी लिम्स मूव करते हैं थ्रू दी अपर लिम्ब। गोल्स होते हैं डिक्रीज एडिमा और पैसिव रेंज ऑफ मोशन 90 डिग्री, 70 से हम उसको इंक्रीज करते हैं 90 डिग्री तक। पार्शियल वेट बेयरिंग उसी तरह स्टिल रहती है विद एक्सटेंशन, ब्लॉक ब्रेस और गेट भी विद क्रचेस। 4 to 6 एक्सरसाइजेस में भी हम अब जो हमने आईटीबी की बात की थी कि हम मैनुअल रिलीज करते हैं, हैमस्ट्रिंग भी करते हैं, अब हम उनके मायोफैशियल रिलीज के साथ कुछ स्पेसिफिक स्ट्रेचिंग एक्सरसाइजेस होती है वो इन्वॉल्व कर देते हैं और रेंज ऑफ मोशन यानी कि फ्लेक्शन के ऊपर मोर कॉन्सेंट्रेट हो जाते हैं, जिसमें हमारी एक्सरसाइजेस हैं फंक्शनल एक्सरसाइजेस, और जो बाकी जो नॉर्मल बेसिक एक्सरसाइजेस हैं वो हम मरीज को फोकस होमवर्क के लिए उसको टीचिंग देते हैं, जिसमें हम पार्शियल स्क्वाट्स करवाते हैं, काफ रेज कराते हैं, मिनी स्टेप अप करवाते हैं, प्रोप्यूसेप्शन एक्सरसाइजेस होती है और स्टेशनरी बाइक करवाते हैं विद लो रेजिस्टेंस और स्लो वॉक करवाते हैं ट्रेडमिल इन फ्रंट ऑफ मिरर, ताकि जो कि वो एक लिम्ब पोजीशन, एक ग्लाइडिंग पोजीशन बनाता है नी की ड्यूरिंग गेट, उसको अवॉइड किया जाए। गेट इसमें हमारा गोल ये होता है कि हम ब्रेस को अनलॉक कर दें और कोशिश करें, यूजुअली हम ऐसा करते हैं कि इनिशियल फर्स्ट वीक में पेशेंट को वॉकर पे रखते हैं, फिर जब उसकी मसल्स की स्ट्रेंथ डेवलप हो जाती है तो नेक्स्ट जो 2 to 3 वीक्स में हम उसको एल्बो केन के ऊपर ले आते हैं, और नेक्स्ट जो हमारे टारगेट भी होता है कि हम 4 वीक में उस केन से भी उसको हटा दें, नॉर्मल गेट साइकिल की तरफ उसको तवज्जो करवाएं। और हमारी जो रेंज ऑफ मोशन है इसमें 90 डिग्री टू 120 जो 4 to 6 वीक्स में टारगेट होती है। 6 to 8 वीक्स में ज्यादा फोकस नी रेंज ऑफ मोशन एक्सरसाइजेस पे हो जाता है और कुछ स्पेसिफिक मस्कुलर ट्रेनिंग होती है अकॉर्डिंग टू मसल्स। इंक्रीज कर देते हैं इंटेंसिटी ऑफ फंक्शनल एक्सरसाइजेस के ऊपर और क्लोज चेन एक्सरसाइजेस की डेप्थ इंक्रीज कर देते हैं, और इसमें शटल लेग प्रेसिंग है और ओवरलोड नहीं करते क्लोज और ओपन चेन एक्सरसाइजेस। क्लोज और ओपन चेन एक्सरसाइजेस ये होती है कि क्लोज चेन में हम जो हमारा डिस्टल पार्ट ऑफ द लिम्ब है उसको हम इंटैक्ट रखते हैं, किसी भी मीडियम पे हम बाकी जो प्रॉक्सिमल मसल्स और जॉइंट्स हैं उनके ऊपर फोकस एक्सरसाइज करवाते हैं, और ओपन चेन में हमारा जो प्रॉक्सिमल पार्ट है वो मीडियम से इंटैक्ट रहता है और डिस्टल पार्ट को हमने ज्यादातर फोकसफुल एक्सरसाइजेस पे रखते हैं। गेट में फोकस हमने यही करना है कि लिफ्ट ना करे, गुड गेट मैकेनिज्म करे, पैसिव रेंज ऑफ मोशन 10 to 135 डिग्री जो कि लास्ट में हमने 120 कहा था, और टॉलरेट 90 डिग्री स्क्वाट। ये मोस्ट इंपॉर्टेंट थिंग है क्योंकि इसमें ही पेशेंट की हमें रिकवरी का पता चलता है। एक्सरसाइजेस में हम लैटरल ट्रेनिंग एक्सरसाइज जिसमें हम साइड स्टेप करवाते हैं, लैटरल स्टेपिंग करवाते हैं और मोर प्रोग्रेसिव क्लोज चेन एक्सरसाइजेस और एचबीपी लेग एक्सरसाइज। अच्छा, एचबीपी लेग एक्सरसाइज में क्या होता है कि इसमें ये डिपेंड होता है, वेलोसिटी डिपेंड एक्सरसाइज होती है। इसमें हम पेशेंट को स्पीडफुल एक्टिविटीज करवाते हैं जिसमें हमारे पास कुछ गैजेट्स होते हैं, उन गैजेट्स के ऊपर उसमें शॉर्ट जंप करना होता है, लॉन्ग जंप करना होता है, और एम्फसाइज करते हैं स्पोर्ट्स एक्टिविटीज की तरफ कि वो अपनी स्पोर्ट्स एक्टिविटीज की तरफ अंडर द ट्रेनिंग शुरू करें, और रोड साइकिलिंग की तरफ उसको लेकर आते हैं ताकि अपने होमवर्क में कुछ ऐसी चीजें एडवांस यूज करें जिसमें उसकी जो मसल्स हैं वो अगेंस्ट द ग्रेविटी थोड़ा सा लोडिंग, इसेंट्रिक लोडिंग दे सके। फुल रेंज ऑफ मोशन 8 to 12 वीक में हम हमारा जो ब्रेन गोल होता है, और हम नॉन बिल्कुल माइल्ड रेजिस्टेंस, ये समझ लें कि बिल्कुल कोई रेजिस्टेंस नहीं होती, लैटरल ट्रेनिंग में हम स्टार्ट करवाते हैं। क्योंकि होता यही है कि जब भी कोई भी ट्रॉमा होता है नी जॉइंट में, ये रिसर्च की बात है, तो ITB बैंड पेशेंट ज्यादा यूज करने लग जाता है VMO की वीकनेस की वजह से। तो उसको लेटरल कंपार्टमेंट में पेन्स जाते हैं, जो कि उसकी ग्लूटियल मसल्स को वीक करते हैं, और आगे जाके फिर बैक के मसल्स को भी वो कॉम्प्रोमाइज करते हैं। 12 to 16 वीक्स में हम 3 मंथ स्पोर्ट्स टेस्ट करते हैं, और उसको कोशिश करते हैं कि वो अपनी रनिंग एक्टिविटीज की तरफ आए। स्पोर्ट्स टेस्ट क्या होता है? स्पोर्ट्स टेस्ट में हमने कुछ एक्सरसाइजेज, जिसमें बर्पीज एक्सरसाइजेज होती है, तो अपर लिम्ब लोअर लिम्ब की कोऑर्डिनेशन एक्सरसाइजेज होती है, उसको हम फोकसफुली करवाते हैं, उसकी स्कोरिंग करते हैं, मसल ग्रेडिंग करते हैं। अगर वो उसमें पास हो जाता है तो फिर हम उस प्रोटोकॉल को आगे लेके चलते हैं, और कोशिश ये करते हैं कि ये कंटिन्यू रखे माइल्ड एक्टिविटीज के साथ फॉर 16 वीक्स, और इनिशिएट करते हैं रेजिस्टेड एक्सरसाइजेस इन लेटरल प्लान में। और गोल यही होता है कि हम पेशेंट को प्रॉपर प्रिपेयर करें उसकी, अगर वो किसी स्पोर्ट्स में या किसी फंक्शनल एक्टिविटी में बहुत इंटरेस्टेड है, उसकी तरफ उससे हम पूछ लेते हैं। बहुत ज्यादातर हमारे जो होते हैं म्यूनिसिपल टीयर में, हमारे यहाँ तो स्पोर्ट्स इतनी कॉन्सेंट्रेटली खेली नहीं जाती, लेकिन वहां पर जो भी म्यूनिसिपल टीयर के पेशेंट आते हैं उनमें ज्यादातर स्पोर्ट्स मैन ही होते हैं। तो हम उनसे पूछते हैं कि आप कौन सी प्रोफेशनल स्पोर्ट्स खेलते हैं, तो उसकी तरफ हम तो ज्यादा कॉन्सेंट्रेट एक्सरसाइजेस और मॉडिफाइड एक्सरसाइजेस करते हैं। जी थैंक यू। सवाल?
स्पोर्ट्समैन में आप कब उनको फुल एक्टिविटी की इजाजत देते हैं? स्पोर्ट्स कितने वीक्स के बाद?
यूजुअली तो जो स्पोर्ट्समैन होते हैं उसकी मसल ब्रीडिंग काफी अच्छी होती है कंपैरेटिवली एक नॉन स्पोर्ट्समैन की, क्योंकि वो ऑलरेडी स्पोर्ट्स में इन होते हैं, तो उसने अपने क्वाड्स और एक्सेसरी मसल्स काफी बिल्ड किए होते हैं। तो हम सिवियरिटी के ऊपर देखते हैं कि पेशेंट की सिवियरिटी और इरिटेबिलिटी कितनी है। यूजुअली जो रिसर्च कहती है कि आप 8 to 12 वीक्स में उसको अलाउ कर दें, लेकिन ये टोटली डिपेंड होता है मसल ब्रीडिंग।
तो मेरा सवाल ये है कि आप ऐसे BTB करते हैं, राइट सर? डॉक्टर नवी जुम्मन हैमस्ट्रिंग वगैरह, तो उन आप दोनों की जो पोस्ट ऑफ रिहैबिलिटेशन में कोई फर्क है, या फॉलो द बोथ द सेम प्रोटोकॉल?
Well, depends on what we tell to our patients, but most of them end up with him. So as long as this is a constant person, they go through the same.
और अगर भी कोई स्पेशल इंस्ट्रक्शन होती है अकॉर्डिंग टू सर्जन, तो वो हम कम्युनिकेट भी कर लेते हैं सर से, नवीद साहब से, और हमारा एक पैटर्न है रेफरल पेज, उसके ऊपर स्पेशल इंस्ट्रक्शंस लिखकर भी दे देते हैं, तो हम उसके ऊपर फोकसफुली एक्सरसाइज।
Ligament reconstruction, when will he go back to his original sport?
Sir, it's totally depend on the muscle activation and muscle strength. Normally, according to research, it will be come back around 8 to 10 weeks. If
6 months,
yeah,
there is new ligament which is going to be activated and replanted. You have done reconstruction. So basically, it's letting you like sports concept, contact sports या normal sports. Contact. तो कॉन्टैक्ट स्पोर्ट्स के अंदर जो बेसिकली रिकमेंडेशन है 6 to 8 months तक है, लेकिन अब नॉर्मल कोई गोल्फ प्लेयर है, कोई नॉर्मल ऐसे एक्टिविटीज है, सो यू कैन स्टार्ट विद रूटीन आफ्टर 3 to 4 months. So it all depend patient to patient. अब रग्बी प्लेयर है, उनका एक अलग प्रोटोकॉल है, रिटर्न बैक टू स्पोर्ट्स, तो सो इट्स फुटबॉलर कॉन्टैक्ट स्पोर्ट्स में आ जाता है, तो दैट्स व्हाट वी।
अच्छा, लोगों को तरह ये सवाल रेजिडेंट्स को क्लोज चेन और ओपन चेन एक्सरसाइज क्या फर्क है, और पहले क्या कराते हैं बाद में कौन सा कराते हैं? जरा इनके लिए एग्जाम में भी पूछा जाता है।
जी क्लोज और ओपन चेन एक्सरसाइजेस पहले जो 2012 में रिसर्चेस हुई उसमें ये कहा जाता है कि कोई भी स्पोर्ट्स इंजरी हो स्पेशली नी में उसमें हमने इनिशियल 3 to 6 वीक्स में क्लोज चेन एक्सरसाइजेस करवानी है देन ओपन चेन। लेकिन 2012 के बाद कुछ रिसर्चेस और ये सिनेरियो चेंज हो गया कि आप लो एक्टिविटी और ओपन चेन एक्सरसाइजेस भी करा सकते हैं। अब होती क्या है क्लोज चेन में जिस तरह मैंने बताया कि हमारा जो डिस्टल पार्ट है, डिस्टल पार्ट अगर हम एक लिंब का लेते हैं तो वो हमारा एंकल रीजन है, वो इंटैक्ट होना चाहिए किसी भी मीडियम से। और जो ओपन चेन है उसमें हमारा जो ये डिस्टल पार्ट है ये ओपन होता है और जो प्रॉक्सिमल पार्ट है लाइक हिप लाइक नी ये इंटैक्ट होता है मीडियम के जरिए और हम एक्सरसाइजेस करवाते हैं डिस्टल पार्ट के ऊपर। इसकी एग्जांपल कुछ इस तरीके से है जिस तरह हमारे पास थेरा ट्रेनर एक एक्सरसाइजेस है, ये एडवांस एक्सरसाइजेस है, इसमें हम पेशेंट का लिम्ब फिक्स कर देते हैं और लिम्ब और टोटल मरीज जो फोकस एक्सरसाइज करते हैं नी के ऊपर और हिप के ऊपर। राइट, अगर मैं अपना एंकल फिक्स करता हूँ तो मेरा एंकल फिक्स है उस साइकिल के पेडल और मैं एक्टिविटी कर रहा हूँ, तो ये क्लोज होगा या ओपन होगा? ये क्लोज होगा क्योंकि डिस्टल पार्ट इंटैक्ट में। अगर मैं एग्जांपल होता हूँ, बहुत से जो हमारे रेजिडेंट हैं वो क्लिनिक में एक्सरसाइजेस सिखा रहे होते हैं SLR स्ट्रेट लेग रेज, ये क्लोज चेन है या ओपन चेन है? ये ओपन चेन एक्सरसाइज है। डायनामिक कॉर्ड्स जिसमें हम नी के नीचे रोल रखते हैं और एंकल को लिफ्ट करवाते हैं, तो ये भी ओपन चेन एक्सरसाइजेस में आते हैं।
अगर थ्योरेटिकल डिफरेंस पे बताएं कि अगर फिक्स कर देंगे तो उससे क्या फर्क पड़ रहा है मसल के ऊपर और ओपन कर देंगे तो क्या पड़ रहा है?
हाँ बिल्कुल सर, ये आपने अच्छा सवाल पूछा। ये इसेंट्रिक डिसेंट्रिक लोड एक्सरसाइजेस होती हैं। इसमें जब हम पेशेंट को फिक्स कर देते हैं उसका डिस्टल पार्ट, तो वो मसल अपनी लेंथ को लिमिटेड रख के उसकी टोन के ऊपर ज्यादा फोकस एक्सरसाइजेस करता है। और जब हम मरीज को ओपन चेन एक्सरसाइजेस करवाते हैं तो वो टोन के साथ साथ अपनी लेंथ भी यूज करता है। तो इस वजह से हम ये ओपन और क्लोज चेन का कॉन्सेप्ट, लेकिन 2012 में रिसर्चेस आई उसमें ये कहा है कि आप इनिशियल फर्स्ट वीक में भी ओपन चेन यानी कि लो एक्सरसाइजेस ऑफ ओपन चेन जिस तरह असिस्टेड SLR हो गई, SLR प्लस एडक्शन एबडक्शन होगी फॉर एक्सेसरी मसल्स करवा सकते हैं। तो थ्योरेटिकली ये है कि मसल लेंथ एंड मसल टोन। तो क्लोज चेन में हम ज्यादातर मसल टोन के ऊपर फोकस होते हैं, लेंथ यूज नहीं करते, और उसमें हम टोन प्लस लेंथ यूज कर रहे हैं।
अगर दोनों में स्ट्रेंथ बराबर स्ट्रेंथन होगा मसल,
क्लोज चेन में ज्यादा होगा, ओपन चेन में ज्यादा होगा क्योंकि उसमें मसल्स फाइबर्स को ज्यादा कॉन्ट्रैक्शन मिल रही कंपैरेटिवली क्लोज चेन की।
Is there any difference between range of motion?
यस, क्योंकि अगर के मसल लेंथ होगी, मसल अपनी लेंथ कंप्लीट देगा तो तभी जॉइंट जो है अपने प्लेन में मूव करेगा। If quads are stiff and IT bands is totally tight, hamstring is totally tight, so knee joints never move in that plane.
Open chain में ज़्यादा range of motion होगी या closed chain?
ओपन चेन में ज्यादा होगी। हाँ, ओपन क्लोज चेन में तो जस्ट मसल इनिशिएट करेंगे हम, उस मसल की एक्टिवेशन करवा रहे हैं।
मगर ओपन और क्लोज की एक्सरसाइज पे भी डिपेंड करेगा ना। स्ट्रेट लेग रेजिंग में शायद रेंज ऑफ मोशन इतना ना हो नी का, पर अगर आप साइक्लिंग करा रहे हैं जो कि क्लोज चेन है उसमें रेंज ऑफ मोशन ज्यादा हो जाए।
जी बिल्कुल आपने सही बात की। बेसिकली ये डिपेंड करता है कुछ एक्सरसाइजेस के आप जॉइंट प्ले कितना इन्वॉल्व कर रहे हैं। होता ये है कि सर्जरी के बाद पेशेंट फोबिक होता है। अगर आप उसकी फॉर एग्जांपल एज ऑफ द टेबल पे नी डेंगल भी करें ना तो वो बहुत अपने हिप्स को लिफ्ट करेगा। तो इस वजह से हम क्या करते हैं कि हम क्लोज चेन के ऊपर फोकसली वर्क करते हैं ताकि वो अपने मसल्स की स्टिमुलेशन और मसल की एक्टिवेशन करे, देन फिर आहिस्ता 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 हम ऐसी एक्सरसाइजेस डिजाइन करते हैं जिसमें वो जॉइंट प्ले भी यूज करता है। ये डिपेंड करता है कि आप किस टाइप ऑफ एक्सरसाइजेस पे उसको इनरोल कर रहे हैं। अब रिसेंटली डॉक्टर नवीद ने एक पेशेंट हमें रेफर किया था, वो ग्रेड 2 मिनिस्कल टेयर था अकॉर्डिंग टू एमआरआई। जब हमने उसको चेक किया तो वो पेटोरोफिमोरल डिस्फंक्शन में था, आईटी बैंड बहुत टाइट था जिसकी वजह से वो अपना इनसाइड द नी प्रेशर बढ़ा रही थी। तो जब हमने उसको आईटी बैंड रिलीज किया, एक्टिवेशन कराई क्वाड्स की, हैमस्ट्रिंग रिलीज किया, तो मेरे ख्याल से सेकंड डे पे वो बिल्कुल पेन उसका जीरो हो गया और वो हम उसको फेज 2 यानी कि ओपन चेन एक्सरसाइजेस के ऊपर गए और अब वो फेज 3 में एक्सरसाइजेस कर रही है। तो ये टोटली मरीज की मसल ग्रेडिंग और कौन से मसल्स को वो यूज कर रही है या कर रहा है उस पर डिपेंड करता है।
अच्छा, एक क्विक क्वेश्चन मेरा फैकल्टी से ये है कि उधर से शुरू करते हैं। डॉक्टर इरफान, आफ्टर ए मेनिस्कल रिपेयर जो भी टेक्निक से आप करें, व्हेन डू यू स्टार्ट वेट बेयरिंग?
Sir, on the first day, partial weight bearing starts.
और फुल वेट बेयरिंग कब?
Full weight bear after 8 to 12 weeks.
So Dr. Irfan says full weight bearing after 8 to 12 weeks. Dr. Naveed?
After 6 weeks.
6 weeks.
Non-weight bearing, manual inflection of 6 weeks. Posterior arm की होती है, mainly posterior arm की होती है ज़्यादातर.
So 6 weeks के बाद full weight bearing.
Full weight bearing.
खालिद साहब?
बेसिकली तो ये आपने जब रिपेयर कर दी है, इफ यू आर वेटिंग फॉर द हीलिंग टू अकर, देन यू हैव टू वेट अ लॉन्गर पीरियड। और अगर आप सिर्फ अपनी रिपेयर की स्ट्रेंथ के ऊपर करना चाहते हैं तो वो जैसे इरफान कह रहे हैं आप डे 1 पे भी कर सकते हैं।
So depending on the repair strength, that's how you practice. Dr. Kazim?
So basically non-weight bearing for 4 weeks and range of motion is set to 90 degree, and after 4 weeks I start with the partial weight bearing for another 2 weeks, and around 6 weeks I start with the full weight bearing.
Yeah, I also am quite hesitant to allow full weight bearing in the first 12 weeks. So it starts from toe touch, gradual partial, and then by 12 weeks I am full weight bearing. Or usually I do mostly outside, inside out repair. So as you see, most of us are hesitant to do full weight bearing after meniscal repairs because we want the biology to come into action. Just only holding the suture holding the two ends of the meniscus would not make it, right? So the biology has to work, the meniscal end have to heal naturally, and then you allow weight bearing. Obviously, range of motion to our foreign law, that's a non-weight bearing thing. And rehab आप फौरन शुरू कर देते हैं जैसे talk. So thank you very much, sir. Good, nice talk, good discussion. Let's move on.
एक सवाल आपसे मेरा, even if you allow movement of the knee, loads तो फिर भी meniscus के ऊपर पड़ रहे हैं. Non-weight bearing में भी biomechanically loads तो उसके ऊपर पड़ेंगे जब आप movement भी कराते हो. तो
पर जैसे वो आपने खुद ही कहा था, एक्सियल लोड नहीं पड़ रहा उस वक्त, और मूवमेंट में जो लोड है, दिस इज अ लोड, नो डाउट, द कंडाइल इज स्टिल प्रेसिंग, बट इट इज सब्सटेंशियली, अब मुझे आई कैन नॉट गिव यू ऑब्जेक्टिव नंबर्स, बट जो एक्सियल लोड है वो आप माइनस कर रहे हैं, एंड मूवमेंट का लोड तो मेरा नहीं ख्याल तो ज्यादा होगा. I think all of us check our repairs intraoperatively with the range of motion. इतनी stable तो सबकी repair होती है, तभी तो हम दिखाते हैं मरीज को that we have done repair and we do range of motion on table, and then we see again that our repair is holding on. That's the point where we come up finally. So Dr. Meet, हम जरा रुकते हैं, थोड़ा सा हम वो करते हैं, लोग को जगाने के लिए ऑनलाइन टेस्ट और कुछ फैकल्टी को भी जगाने के लिए पूरी के बाद हाँ हम जूम पे ही करेंगे. तो फैकल्टी की मार्किंग नहीं होगी, आवाज नहीं आ रही उनको. शाम साहब आवाज आ रही है?
ये खुद ही म्यूट है। आज ही तो उन्होंने वहां से म्यूट किया। ये देखो ना, ये देखो।
हेलो,
हाँ
आ रही है, आ रही है।
अरुण साहब
जी जी जी, हाँ हाँ आ रही है।
अच्छा, वो इस्लामाबाद नहीं जा रही, आप करीब है ना?
आप वैसे भी दिल के करीब हैं। हेलो,
हाँ जी, हाँ जी। अरुण साहब, एनी कमेंट सो फार, एनी क्वेश्चंस?
हाँ, मेरा सवाल ये है कि व्हाट इज द डिफरेंस बिटवीन फोर्स ट्रांसमिशन in a closed chain and open chain exercise?
डॉक्टर हारून ने सवाल। जी डॉक्टर हारून, आपका सवाल ये है कि क्लोज चेन और ओपन चेन में हम मसल की फोर्स कैसे ट्रांसफर करते हैं?
फोर्स ट्रांसमिशन में क्या फर्क है?
फोर्स ट्रांसमिशन में क्या फर्क है?
नी जॉइंट पे फोर्स ट्रांसमिशन।
हाँ, नी अक्रॉस द नी।
जी जी, जो क्लोज चेन एक्सरसाइजेज होती हैं, अकॉर्डिंग टू रिसर्च वो ये कहती हैं कि उसमें जो फोर्स डायवर्जन, जिस तरह सर ने कहा कि शॉकिंग एबिलिटी, जो शॉक फोर्सेस होती हैं वो लो होती हैं कंपैरेटिवली ओपन चेन एक्सरसाइजेज में। उसमें हम जॉइंट के ऊपर लोड कम में मसल की एक्टिवेशन पे ज्यादा फोकस होता है, और जो ओपन चेन होता है उसमें ज्यादातर नी जॉइंट पे ऊपर ज्यादा शॉकिंग फोर्सेस डेवलप हो रही होती हैं कंपैरेटिवली क्लोज चेन के।
ओपन चेन पे नी पे कम लोड आए और क्लोज चेन पे ज्यादा।
हाँ, ये बहुत बड़ी एक कंफ्यूजन रहती है। बेसिकली प्रैक्टिकली ये होता है कि जब आप मरीज को अटैक करते हैं एक्सरसाइज में, तो वो आप किस तरह के गैजेट्स यूज कर रहे हैं। फॉर एग्जांपल, मैंने एक एग्जांपल दी कि आप थेरा ट्रेनर यूज कर रहे हैं। थेरा एक असिस्टेड साइक्लिंग है, इसमें आपने लोअर एंकल फिक्स कर दिया। जब एंकल फिक्स किया और जब आप प्रेशर दे रहे हैं, तो प्रेशर के दौरान जो आप अपनी नी को, हम उसमें एंकल फिक्स कर देते हैं क्लोज चेन में, कि मरीज का जो नी रेंज ऑफ मोशन है वो 20 डिग्री से ज्यादा ना हो अकॉर्डिंग टू पेन के होता है। इसमें मरीज की जो शॉकिंग एक्टिविटी होती है वो इतनी फोकस नहीं होती टू अगर ये प्रैक्टिकल चीजें होंगी तो इसमें ज्यादा रहेंगे थोड़ा सा कंफ्यूजन रहती है। ज्यादातर लोग क्लोज चेन के ऊपर ज्यादा शॉकिंग
किसी के दो डिवाइस है ना, एक और सही वन से।
हाँ इसी पे।
हाँ
तो ऐसे ही सुन रहे हैं मेरे ख्याल में।
अच्छा जी, ये सब लोग लॉग इन कर लें, सब लोग फैकल्टी लॉग इन कर अपने अपने नाम से लॉग या कोई कोड नाम डाल।
हाँ हाँ, ये तो वो इसको बंद करना है।
म्यूट कर देते हैं। शुरू कर रहे हैं, हमें कमेंट कुछ करना है।
आपने वो करना है।
हाँ
इस पे तो करें, वो लोग लॉग इन कर रहे हैं।
अच्छा सॉरी, मैं सर वो टॉप पे होगी तो मैं इसको बता दूं।
ओपन कर ले, अब ओपन कर ले, प्रॉब्लम सॉल्व।
प्रॉब्लम ये है कि आपने लिगामेंट रिपेयर किया है एंड यू डोंट वांट एक्सेंट्रिकली लोड द नी। ACL के बाद यू डोंट वांट एक्सेसिव मूवमेंट एट द कॉर्डर, तो उसका एंटागोनिस्ट अपोजिट है। यू वांट मोर मूवमेंट ऑन हैमस्ट्रिंग पे हो तो इट्स बेनिफिशियल फॉर ACL। SLR जैसे मिसाल देने के ओपन चेन, मिसाल एक ले लें कि मैं अगर नी को 45 डिग्री मुझे फ्लेक्स करना है, when I'm flexing तो it's hamstring only working, I'm extending it's only quadriceps working। लेकिन same movement मैंने fix करके और इस तरह से मैं अगर bend कर रहा हूँ तो now I have all the muscles are working, knee is more stabilized. The difference primarily यही है. You want all the muscles around the knee or any joint to stabilize the knee or any joint at the same time simultaneously. एक तरफ ज़्यादा movement ना हो. There is the difference between open and closed chain. Same movement 45 degree of the knee with free foot single muscle group कर रहा है, with the fixed foot आपके दोनों muscle काम कर रहे हैं.
Joint load किसमें ज़्यादा हो रहा है?
Load आपकी closed chain में हो, closed chain में हो रहा है.
Exactly. No, sir, let me. वो सवाल मैंने जो पूछा था ना. Now this fist formation transmit 100 Newton of the forces. Right? This transmit 100 Newton forces. So if I am doing any reconstruction, I will guide the patient the activity which is allowed like up to 100 Newton. But on the other hand, this holding this hand transmit maybe 10 or 15 Newton. So this is to me is a closed chain, and this is open chain. So maybe this. So closed chain transmit less amount of weight, so maybe a good way of advising patient in initial part of any reconstruction. And open chain, because it transmits a lot of maybe 10 times, 20 times more forces, so will be advised in a later part of reconstruction. So I'm just want to make myself. Yes, so that may be an easy way to relate to the resident.
इसमें आपका जो range of movement है ना, angles, उसने force increase कर दी है. जब आपने grip किया wrist को, तो वो
नहीं इसी grip में making a fist without doing anything, normal fist. This just fist, normal. जोर भी नहीं लगाना.
All these are ये जो angle है, इसने resultant force बढ़ा दी है. जब आप थोड़े angle पे move करोगे, वो force कम होगी.
Sometimes interpretation may be different हो. जब तक मेरा हाथ खुला है, this is open chain. जैसे ये contact में आ जाएगा, this is closed chain now. मतलब मैं तो शायद probably इस तरह का हूँ. अगर ये contact में नहीं आ रही toes palm के साथ, तो this is open chain now. Contact में आ गई तो closed chain convert हो गई.
अच्छा. Another way is if you fix a rod to this wall with 2 bolts, you need a stronger fixation. If other end is free, this is open chain. But if you fix the both end of the rod, you will need lesser amount of fixation on both sides. So this is a closed chain. So this is how I make my concept clear. And that applies to hip also. A non-weight bearing ambulation transmit more energy, more forces than a weight bearing on the hip joint. So even SLR like transmit 10 times body weight. But if you are walking, that may be just your leg weight. So that is how.
जैसा कि सर आपने कहा कि जॉइंट फोर्स किस में ज्यादा लगती है, कि सब कह रहे हैं कि क्लोज चेन में ज्यादा देखने में ज्यादा लगती है और ओपन में कम लगती है. होता ये है कि जब हम क्लोज चेन में एक्सरसाइजेस करवाते हैं, जब मीडियम से इंटैक्ट करवाते हैं, तो उसमें ग्रेविटी असिस्टेड हो जाती है, जिसकी वजह से ग्रेविटी असिस्टेड होने की वजह से जो फोर्स डाइवर्ट हो जाती है थ्रू दी मसल्स, तो जॉइंट के ऊपर इतना फोर्स नहीं आ रही होती. दिखने में तो अलग होता है, लेकिन वो ग्रेविटी असिस्टेड होती है. लेकिन जब हम ओपन चेन में आते हैं तो वो ग्रेविटी एलिमिनेटेड एक्सरसाइजेस कर रहा होता है, जो कि मसल टोन और जॉइंट स्ट्रेस ज्यादा डाइवर्ट कर देते हैं जॉइंट के ऊपर. तो इस वजह से एक ये पॉइंट है कि ओपन चेन में ज्यादा जॉइंट स्ट्रेस ले रहा होता है कंपैरेटिवली क्लोज चेन थ्रू द ग्रेविटी असिस्टेड एंड ग्रेविटी एलिमिनेशन.
अच्छा जी, सबने कर लिया? ये सबने कर लिए? 13 लोग हैं, फिर लोग तो ज्यादा हैं. तो अस्सलाम वालेकुम. स्मार्टफोन सब रेजिडेंट्स ने कर लिए?
या सब अपने सेल फोन्स में लॉगिन कर सकते हैं kahoot.it पे. I request all the faculty who are online and who are present over here to join via their cell phones using Google Chrome or Safari, whatever. Kahoot.it, and then put the pin as shared on the screen.
चलें जी शुरू करें बिस्मिल्लाह.
So there are only 18 participants now. So should I start?
वो पता नहीं ऑनलाइन वाले फैकल्टी हेजिटेंट है, लेकिन आप शुरू करें.
Okay, sir. So there are 20 questions, 1 minute each, and you'll have to select one answer for each question. So in arthroscopic repair of lateral meniscus with an outside-in technique, the way to prevent damage to the peroneal nerve is. We'll move on to the next question. Meniscus repair is most successful for tears in which of the following zones? Which of the following does not improve meniscal repair outcomes in avascular zones? Which tear pattern is most responsive to meniscus repair? Which of the following meniscus repair techniques results in the highest pull-out strength? Which of the following is the most important factor for meniscus repair success? What is the major technical limitation of open meniscal repair? Which of the following is the main advantage of an all-side meniscal repair compared to the inside-out repair? To arrive from the depressed medial tibial plateau, fractured peripheral medial meniscus tear is identified. Treatment should be. Which of the following methods of meniscal repair has the highest load to failure strength? Complication is more likely with an inside-out repair technique compared to an all-inside technique for a millimeter tear. Which of the following factors is most critical to the success of a meniscal or allograft transplantation? 21-year-old soccer player reports pain and unable to straighten his knee after an acute injury. He is unable to play. Next step. Which factor increases the success rate associated with all inside lateral meniscus repair? So it's a healthy activity in your old man has acute onset right knee pain and inability. So I'll just let you guys read it yourself. All right. So moving on to the last question. So the question is pretty obvious here. What would be the treatment of this patient? All right, that's it. We're done with the quiz. So now we'll see who is third. AG, some number, and then some number again. So congratulations, whoever is 10287 is. Oh, sorry, MKRN. Yeah.
Oh, faculty. Who is AG? AG, very good. 4706160, Pesa. Zabardast. All right, so good.
Right.
So let's move on. Visa has the next talk. Degenerative meniscal repairs पे सवाल भी हुआ था degenerative knee में क्या करना चाहिए यानी elderly लोगों में meniscus को कैसे handle करना है. That's another aspect of another dimension of this problem. So over to you, Dr. Nabil.
क्या मिलेगा एक्स्ट्रा पोर्शन लंच पे?
इनको 2 डब्बे मिलेंगे और सेकंड और थर्ड आने वाले को 1.5 डब्बा.
ये मिनिमम से बैक लॉन्च होगा. स्क्रीन शेयर से यहीं से डायरेक्ट ये तो मेरी. So I don't have a lengthy presentation, छोटी सी presentation ताकि टाइम बच सके. So we have talked a lot already कि क्या करना चाहिए and what meniscus need repair, what need resection. So and also we touched little bit discussion में कि क्या करना चाहिए. Arthritic knee means these are not 40 plus. These are usually 55, 50 plus patients who come with to you in an age where you already suspecting arthritis, and they do have arthritis already. So it's not post meniscectomy or post an injury. It's a natural arthritis, and you want to know. We like to see what is the evidence to deal with these patients. Presenter. So historically, knee was a model joint for arthroscopy. Both diagnostic and therapeutic applications of a scope debuted on knee primarily. Then other joints were involved. So arthroscopic technique, and when you are talking about meniscal injuries or dealing with meniscal injury in the knee, you are also talking about whether the scope is per se indicated in arthritis knee or not. So historically, there was a role of arthroscopy in the knee, including the lavage of the joint, debridement, aberrant arthroplasty, microfracture, and dealing with the meniscus. So prior to 2002, there were no rigorous, adequately powered randomized controlled trials, and after that there were very good trials published, RCTs and meta-analysis as well, which had good power and which were followed by different societies of the world that have changed the management of these patients. So one of them, the famous trial was the Mosley study, a landmark trial in 2002 that fundamentally altered the role of arthroscopic surgery in patients with osteoarthritis who were diagnosed with arthritis, and obviously their diagnosis is usually made with the standing X-rays. The study arms include arthroscopic debridement, arthroscopic lavage, and a Sham procedure where you don't do anything, just give the step wounds and don't go inside the knee. So all the groups show early pain reduction, all 3 groups, followed by essentially no change in pain through 2 years of follow-up. So any arthroscopic intervention did not improve pain or any functional outcome in long term. There was another study, Kirkley study, this is also a pivotal study of the efficacy of arthroscopy for knee OA, and they obviously excluded those who had a Buckenhall tear. So we see complex tears in these patients, and then there is a different group which has Buckenhall tear. We will discuss what are their symptoms and what we should be doing in those patients. So agreed upon written protocol were followed in all the groups, that is the debridement, synovectomy, excision of degenerative tears in the meniscus, and fragments of cartilage and excision of osteophyte that prevented full extension. Now, this trial did not identify a statistically significant or clinically meaningful difference in pain or functional status between those randomized to physiotherapy or those randomized to partial meniscectomy or to the with the physiotherapy. So there was no difference whether to do a physiotherapy alone or you do a meniscectomy and then followed by physiotherapy. So historically, a number of non-randomized studies had documented the value of arthroscopic partial meniscectomy in patients with meniscal tear. So obviously, as I told, so this was these old studies which were not very much, did not have very much power. So one study is Highland study, and the subjects were 96, 45 to 64 years of age who have arthritis. And they have meniscal tears on MRI as well with the knee OA, radiological evidence of knee OA, and but usually minor joint space narrowing. And these are the patients which we will be seeing what need to do and what should be our protocol. So minor changes on X-rays, minor joint line space narrowing, and MRI showing meniscus tear. So the groups were randomized to a rigorous exercise regime alone or to the same exercise regime with partial meniscectomy. So both improved considerably over the first 6 months and maintained improvement in pain and functional status over 60 months. And about 30% of patients who only went for physiotherapy, they converted to arthroscopy. So both approaches were fine, but in conservative group, there were more chances of going to the surgical intervention. So that's how, I mean, this study might encourage you to go for arthroscopic meniscectomy in patients who are not responding to conservative management with arthritic knees. So there's another study, a meniscal tear in osteoarthritis research trial, and subjects were randomized to receive either a standardized physiotherapy regime that emphasized strengthening or arthroscopic partial meniscectomy with post-operative physiotherapy. So both groups improved considerably in the first 6 months with no statistically significant difference, clinically or clinically important difference at 6 to 12 months of follow-up. So again, only short-term benefit, no long-term benefit. So if you are doing physiotherapy alone or doing a meniscectomy with after and followed by physiotherapy. So GM study, this is also a famous study. Ososcopic partial meniscectomy versus non-operative regime focused on strengthening. Both groups improved considerably with no clinically important or statistically significant differences in improvement in any of the key outcome measures. And again, no difference. So majority studies are saying no difference. Only one study which showed that conservative group, 1/3 of those patients may go for meniscectomy. Again, another study, landmark trial, RCT of arthroscopic partial meniscectomy versus sham surgery for degenerative arthritis or meniscal tears. And a good number of patients, 146, from 35 to 65 years, symptoms of degenerative medial meniscus tear and no knee osteoarthritis. I mean, these are older group patients. So either meniscectomy versus sham surgery, both arms showed substantial improvement in pain and function in the first 2 months, followed by surgery with no significant or clinical improvement differences after 12 months. So again, only short-term benefit, no long-term benefit. So काफी surgeries हैं इस तरह की, I mean, a lot of studies are there which are showing very minimal short-term benefit, no long-term benefit if you go for meniscectomy in this age group, 45 to 65, and who have knee arthritis and plus degenerative meniscal tear. Studies of mostly et al. And Kickley et al. Argue compellingly that arthroscopic lavage and debridement should not be done for the knee OA patient per se. And interpretation of obviously meniscectomy, there is no role of lavage and debridement, ये तो clear हो गया. But with meniscal tear, studies are relatively still controversial. जैसे किसी यही study आ गई कि ultimately 1/3 of patients are requiring meniscectomy, so you might consider early meniscectomy in those patients. So mostly, most of the societies of the world have opted not to offer arthroscopy in arthritic patient, but with meniscal symptoms, you may change your approach. So उसके आगे देखते हैं क्या है. So So it is reasonable to explain to patient with knee OA that arthroscopy should not play a role in their symptom related with arthritis. Only if they have a very specific meniscal symptoms like catching, locking, popping, and relatively acute onset of symptoms on their chronic symptoms, then you might consider to offer them arthroscopy for meniscectomy. Now, in patient with OA and symptomatic meniscal tear, a course of physical therapy focused on strengthening is a reasonable recommendation. Majority of patients will benefit from that, but we know from the trial that 1/3 of patients may require meniscectomy. So if the patient is not improving with the conservative trial, then you can offer them arthroscopy and meniscectomy. So patients who fail to improve following a course of physiotherapy can be referred for partial meniscectomy. And so no level 1 evidence, obviously we don't have very strong evidence, but some, just मैंने जिक्र कर दिया yesterday, suggesting you can offer them meniscectomy. So again, I mean, this is the evidence available. So again हम उसी पे आ जाएंगे जो previous discussion था कि grade 2 meniscus and उसमें हम क्या करें. So same will apply here. You have to correlate symptoms with the patient, with the investigation and with the findings. Age is absolute age is not important. So I have a patient, for example, a 60-year or 65-year-old, relatively good functional knees. Patient आपको आके बताता है कि 2 महीने पहले तो नीचे बैठ के नमाज पढ़ रहा था, suddenly pain शुरू हुआ है, and the symptoms are pointing towards a particular area of the knee, suppose medial, posterior or lateral joint line tenderness. MR is also suggesting that there is a complex tear in that area. And then probably this is the patient whom an X-ray is showing that there is a fairly preserved joint space. It's not advanced arthritis. Grade 1 or maximum grade 2 changes in Calgren-Lawrence. So these are the patients where you can, with the confidence, advise for meniscectomy. And but if the symptoms are not correlating, patient is complaining of medial side pain, MRI दिखा रहा है कि lateral side meniscus tear है, and degenerative arthritis significant grade 3 या उससे ज़्यादा है on your MRI, then possibly it's better not to consider for ososcopic meniscectomy in those patients. Next talk for a meniscal repair. So outside in, inside out, and then all inside. So we will continue later on with the outside in and inside out. And so I will continue with my talk on inside all meniscal repair. So it's mainly the indication and complication. So let's see what you can get from this talk. So the जैसे बात हुई थी कि when the meniscal repair was started. So concept is very old. So first described by Anandel in 1885. But obviously the importance were not clearly understood. And you might be surprised to know in early days of ACL reconstruction, the lateral meniscus was used to be the autograft for ACL reconstruction. So people did not use the importance of the meniscus, and they used to harvest lateral meniscus for the ACL graft. So then obviously we know that lateral meniscus is more important than even medial meniscus in load sharing. So different techniques are utilized. Open, which was being done previously, obviously, when people understood the concept of meniscus repair. Then going to the ososcopic, we have in outside in technique, we have inside out technique, and the other speaker will describe. The name is itself explanatory. You are making sutures from outside in, or you are getting sutures from inside out. And then there is outside in repair. So you don't have to make additional port, and you do all your repair from your standard ososcopic portal. So that's why you don't need any additional incision. So that's known as all inside repair. So gold standard is still the inside out vertical mattress. Probably ये slide अगर देखी होती तो शायद एक question सही हो जाता आप लोगों का. So vertical mattress suture inside out is still gold standard, probably because of its strength. It provides significant tension and strength and to the repair. Success rate is 60 to 80% in isolated meniscus repair, and it is increased up to 90% when you are doing with ACL. And because you are providing more favorable environment for meniscus to heal with the release of blood and growth factors and fibrin and these things. And the same success rate is also with the all inside meniscus repair. Now, all inside techniques have developed to reduce the surgical time, technical difficulty, and risk of neurovascular structure. So these all things are reduced when all inside techniques are developed. So introduced in 1991 have benefited from improvements in devices in technique and are growing in popularity. So a different modality, different devices and different techniques have been developed. And obviously just to make them more and more stable and easy in performance and less complicated. Limitations are obviously still there despite the most advanced techniques in intact meniscus rim is usually required. Usually you don't repair meniscus with the capsule with all inside technique. You have to have some meniscal rim there, which should act as a post to hold your pecs or sutures for all inside repair. And obviously accessibility is difficult in anterior horn here. So now the devices are different techniques available where you can do all inside anterior horn repair as well. Just like 360, the fast fix was shown in the picture previously. So, but technically, historically, the anterior horn was difficult to manage with all inside devices. So, example of different devices, these are the meniscal arrows, the fast fix, the rapid lock from they are different devices from different companies, and then Maxfire from. So these are just examples of different devices from different companies. So we use here usually the fast fix from Smith & Nephew or the Meniscal cinch from the Arthritis, and there are different types to them as well. So different generations are there. Historically, first generation devices are described originally in 1991, and they were curved hooks used through accessory portals to pass sutures across the tear. So similar, just like we use sutured lasso. So they were technically demanding, despite they were successful, repairs were good, but technically demanding, you have to have accessory portals, posterior, posterior, lateral, to pass the lasso or pass the suture in different directions. So technically, we still, after these resurgence of, you can say, the meniscal ramp lesions and root lesions, so we are going back to these techniques, putting accessory portal, posterior, lateral, depending on which meniscal we are doing, and we are passing sutures like this. But due to development of different newer devices, these techniques are usually not done for routine meniscal repair, which were first generation inside repairs. Second generation introduced the concept of technique-specific devices placed across the tear and anchored peripherally. So I didn't got the picture of that device, but these are usually based on some suture anchors. So again, their repair was successful, but there were certain issues, and that's why the third generation and fourth generation devices were developed. So success rate was, short-term success rate was really 80-90% with those devices. So third generation may include a number of devices, including the arrows, screws, darts, staples. I already shared the picture of one of these, the meniscal arrows is a third generation device, and the remaining, these are fourth generation devices. So numerous device specific complications have also been reported with these because they have to be implanted into the meniscus. Sometimes they become prominent or they give away, become a loose body in the knee, or they cause abrasion in the cartilage. They make a sign of inflammation. So these were the problems encountered with many of the third generation devices. Because these were relatively more rigid devices if you consider the meniscal arrows and darts. So this is one of the complications showing a third generation device. So the repair is lost and it's become a loose body or prominent implant. So fourth generation repair devices, they are flexible, they are suture based, low profile, and they allow for variable compression and retensioning across the meniscal tear. So one problem was with many second or third generation devices was that they were fixed devices. I mean, you can, once you fix it, you cannot provide further tension to the repair if the repair is loose. And these devices, with fourth generation devices, they are suture based and they are flexible, and you can provide further tension before cutting the suture, depending on your tear size or tear gap. So one example, I mean, they're very low profile knots, usually 2-0 suture is used and hardly visible on the surface. And clinical results, early results are obviously promising, 91 to 80% success rate with or without ACL reconstruction. Obviously with ACL, the success rate is more as compared to the isolated repair. Complications are still there. With still these much sophisticated devices, you do face complication. Most important is the device misfire and breakage. Chondral damage may still result with these devices as well, and sometimes iatrogenic damage when you are passing the device, you are hitting the cartilage or with the either with the cannula or with the needle, or even these knots sometimes may also become prominent and may cause the chondral damage. And then soft tissue penetration and entrapment of the nerve is still possible. If your needle is too long, which you are using for the passing of the suture, it may cross the capsule and may damage the nerve or soft tissue, or may entrap some other soft tissue, some tendon, popliteal tendon, popliteus tendon, or something which you don't want to entrap in your repair. So obviously, latest devices are trying to prevent these problems. There are stoppers. There are markers which tell you which can make you to fix your needle to a certain length, and it should not pass. It should not cross the capsule. So all-inside repair, popular choice due to some advantages. So there is no posterior incision. You don't have to do a separate incision for tying of the knots, just like you do in inside-out repair. And you don't need an experienced assistant, which should hold the nerves and retract the tissues. And there is a lower rate of complication. There is a question mark, as I told you. There is still rate complications are there, but might be lower than the other repair techniques. And it saves time. I mean, you don't have to give a separate incision, isolate the nerves, and then close it. So you just have to put the sutures with your same incision which you are giving for ososcopy. So many all-inside options and compared designs are available. So I already discussed those things. And peak pledgets versus all sutures, active deployment, deep limitations. There are different pictures. So functional, basic function is same. You have to deploy a suture with some peg attached to it. So usually 2 fires are required. So one fire will launch one suture, the second will launch the second peg, and then this tightening suture, you can pull it and tighten your repair. The basic concept is same. Different devices, different designs are available through different vendors, and they may have advantage from one to other with some more curved needle or more flexibility. Or in latest devices, instead of these pegs, they have all suture material like this. You may see the pictures available on the pamphlets. So they are relatively more lower profile as compared to these pegs. So there are a few disadvantages. The device may misfire or break. This have happened in our practice as well. And these are costly devices. When you are once the peg is out, you cannot go back. So you have to then use another device if you are choosing the wrong side of the meniscus where the needle has passed. And the needles may break inside as well. You have to be very careful. And it may be very difficult to pass the needle into the tight compartments. You can use different techniques like picrusting or something like that. And greater iatrogenic meniscal damage. You can see a hole size with the needle which you use for inside-out repair, and you can see the hole size with the needle which is used for all-inside repair. So iatrogenic meniscal damage is also there when you are doing these problems, and obviously they may potentially, there's a fear that it may potentially propagate the tear further in the future. So cost is obviously high. So if you are considering one meniscal cinch is costing almost 50,000 here. So every patient cannot afford it. And just like, and that's how you define your indication depending on cost and your comfort and availability. So sometimes, I mean, there, Dr. Amir Qureshi told you they are doing mostly repair. All the meniscus they are doing repair, even in the white zone. But I may not agree. There is too much evidence for white zone repair available. So still there are significant failure rates. People there can afford, and we cannot utilize 2 or 3 meniscal cinches for repair, which has a very good chances of failure instead of healing. So if we use 6 of these devices, it may cost almost 300,000. So we have hardly used, maximally I think I have gone to the 3 meniscal cinch, 3 repairs. So I don't know, not more than 3. But in UK, and during my observership or fellowship, I mean, even in my actual fellowship, I have never seen people using more than 3. But in one of the cases, in a child I was observing, it was in UK. So the consultant used one device, second fast fix, third fast fix, and I mean, I was also surprised that he kept using maybe almost a dozen fast fix he used for a posterior horn of lateral meniscus there. So I have to ask from some other person, is he trying to build the meniscus on these pegs or repairing it? But they don't care, obviously, it's a government paid thing. And if I use 12 devices here, it would be more cost than total knee replacement. So potential neurovascular complication is still there, especially lateral side. So lateral side, if you put your needle too long, you may still damage the peroneal nerve, just like open repair. Even in open repair, you are relatively more safe on lateral side because you are isolating the nerves. Here, if you misjudge the direction or you misjudge the length of the needle, there may be more chances of peroneal nerve repair with the all-inside technique. So in comparative data, the comparison of all-inside out and all-inside technique for the repair of isolated meniscus tears, there are 2 famous studies, Grant et al. And then Fleming et al. And 20% failure rate in each study. And obviously 20% failure, that means that you have almost 80% success rate. So they are successfully, so comparative success is comparative to the gold standard, which is inside out. So you can't argue that it's not less successful. So no difference in failure rates, outcome scores, or complication rate. Obviously, because these are latest techniques, the evidence is relatively low. And these studies might have inherent selection bias. So obviously the meniscal tears which do need inside out repair, they go for inside out. They may not do all inside in those patients. So their selection bias might be there in the studies. And favoritism towards inside out for larger tears. So the factors which you need to consider when which method you use or you are going for all inside repair, complexity of the tear is important. Large tears, you may not do all inside. You may have to do some hybrid technique. In complex tear, again, you may not do all inside. And how many sutures will we take to perform anatomical reduction is very important. As I told you, you cannot use 15 or 10 sutures for all inside. They will be very expensive. Technical ease of insertion, whether you are able to reach to a particular area or not with your all inside device. And peripheral limb and rim and metatarsal injury, as I told you, may not be suitable for all inside technique. And neurovascular injury risk is also there. So, and obviously, as I told you, there are chances of delayed tear because the hole size is larger. The suture is very tight. The strength of suture plus damage from the larger bore needle plus tendency to overtension because you want to tighten them further. You want to pull them as tight as part. All these things may combine to a re-tear or in the future their tear may propagate. So lateral side is obviously more important when you're considering neurovascular complications. Posterior approach, but you are obviously trying to avoid posterior approach. But sometimes, as I told you, it might be beneficial to open give the open incision and see the nerve instead of doing blindly with the all inside. So successful meniscal repair requires a comprehensive armamentarium. So you should have know-how of all the technique. You should know role of each technique, where to do, for which tear, for which location to choose what. and become proficient in and learn technical parts for all, and do what's best for the meniscus and the patient. It should not be what's easier for you. It should be what's best for the patient. All inside technique should be reserved for cases where the healing environment is optimal, especially for with concurrent ACL surgeries. And hybrid meniscal repair may be indicated in bucket handle tears because these are relatively larger tears. And hybrid means you may combine all inside with inside out or the outside in. Potential contraindications, as I discussed, the peripheral rim tears and the anterior horn tears. So this picture might give you some idea. So this is anterior, but you can't see the arrow there. So the top is the anterior and bottom is the posterior. So the posterior horns are really difficult to, you are relatively more worried about neurovascular damage when you are doing inside out in the posterior horns. So posterior horns are more suitable for all inside, but you can do both, all inside plus inside out. Body, it is your choice. Again, you can do inside out, outside in, or all inside. With the central part of the meniscus, you can use all three techniques. But for anterior horn, usually outside in is more easy. Inside out may not be convenient, but with newer devices, you can do all inside as well. So this is one of the case, a young patient with the bucket handle tear. You can very well appreciate this is the medial compartment of the right knee, and the bucket handle tear has dislocated in the knee. So obviously you can't resect this in a young patient. You try to repair it. So some debridement is done on the inside edge of the tear, followed by reduction, and then I have tried to do hybrid technique here. So this is a needle passing from outside in. So the meniscus is so unstable, so even while passing the needle, it again dislocated. So in these cases, when you are passing this suture, one suture pass, second suture, so this suture may also help you in reducing the meniscus. So reduce the meniscus, and then I usually don't tie the suture right now. You just hold it, keep the meniscus reduced, and then go for your remaining sutures, which are also all inside. So this is the meniscal cinch 2, which we are using here. First pass and second pass relative distance from the first suture. So this is the horizontal mattress, not the vertical one, the horizontal mattress suture. And then you pull the thread, make your repair tight, and then cut it. And this is the final picture. So one inside out and two meniscal cinch. So that's how the bucket handle might be managed. So thank you very much.
The next part of the talk, actually before that, was how I do outside in repair, and let's move on to discuss few points, and a couple of them Dr. Naveed has already alluded to in his last talk. So first described historically 30 years ago by Warren, and very optimal for anterior third tears and those who do routine arthroscopy. Anterior tears, we don't see that infrequently. So as I mentioned, first described 30 years ago by Warren, optimal for anterior third tears and okay for middle third tears, but I have never done it for posterior third tears. And although theoretically yes, it can be done outside in for posterior third tears, but obviously you need a big incision, protection, and a modified position of the knee for doing them. So the success depends on of each technique, is dependent obviously on my training, the role indication
and my proficiency in how well I can execute a technique. And obviously I will do what's the best for this patient, and obviously what is the best for this meniscus as far as the tear morphology is concerned. So, but the easiest part of outside in is it's very easy to learn and does not require any sophisticated fixation and instrumentation. Or the other very good thing about it, it's a very cheap technique. So the cost is maybe spinal needles and a suture. So maybe a couple of ₹100 as compared to many thousand rupees for an all inside business. So all hospitals who have arthroscopic equipment, a grasper and a hook, all of them have spinal needles and a suture. So I usually use a PDS, but obviously Prolene can also be used. A diagnostic arthroscopy is first performed through the regular portals to evaluate the pathology, and after confirmation the arthroscope is usually placed through the contralateral portal of the compartment of the involved meniscus to visualize the extent and characteristic of the tear. So usually it's not necessary, but for beginners you can begin with a small incision, anterior incision, whether it's medial anterior horn or lateral anterior horn depending on the site and you begin the outside in repair by passing a spinal needle with a direction you determine by the scope, so that you enter through the rim and then you enter through the intact meniscus. For example, as is shown in this picture, if you can see my cursor, this is the longitudinal tear of the anterior horn, and I have passed a cannula or a spinal needle, and I have crossed the tear. And then so this is the anterior incision that I was talking about. You can or you may or may not opt for it. That's an option, especially for beginners, as I said. I only give this even smaller incision at the time of suturing now. So the spinal needle is introduced by piercing the capsule and advancing through both the edges across the tear, as is shown here, and you are at the same time visualizing your introduction of the spinal needle across the tear. Now you withdraw the cannula and you then pass the suture. Whether you use one PDS or 2-0, I think 2-0 is sufficient. I've been doing it with 2-0 Prolene and 2-0 PDS also. Anyhow, and that depends on your personal preference. So once I have passed the PDS suture, this is the first pass, right? The next pass is with another needle, or you can now withdraw the needle, keeping the suture in, and pass another needle as was shown here. Pass another needle across, right? 1 centimeter maybe or less than that to exit at this distance from the first needle, and then you pass a loop through this needle. इसलिए you need 18 gauge needle, not less than that. So अगर आपका 1 suture है तो उसका loop भी मोटा हो जाएगा, इसलिए this is another reason I use 2-0. The loop is smaller and easier to accommodate in this spinal needle. ठीक है, अब आपको loop दिखाते हैं, एक मिनट. तो ये सेकंड पास ले रहे हैं. फर्स्ट पास आप देखें कि पीडीएस सूचर का हुआ है, अब ये सेकंड पास ले रहे हैं. ठीक है, तो ये पिक्चर में अभी आपको समझ, एक मिनट इधर आपको ज़्यादा समझ आ जाएगा. ये फर्स्ट पास लिया, सूचर आ गया, और फिर आपने लूप लिया. ये जो पिक्चर ऑन द टॉप लेफ्ट है, ये लूप आ गया. तो फर्स्ट कैनुला आपने डाला, स्पाइनल नीडल डाला या कैनुला डाला, उसमें से सूचर निकाला, दूसरे में से लूप निकाला, और दे आर अक्रॉस द टीयर, और फिर आपने इस सिंपल सूचर को उस लूप में से गुजार के पुल आउट कर लिया, जैसे पिक्चर ऑन द बॉटम ऑन द लेफ्ट साइड है. ठीक है, वो आपको हुक से करना पड़ता है या ग्रास्पर से आप उसके थ्रू चले जाएं. दैट्स अभी वो वीडियो में मैं दिखा देता हूँ. ये उसने हुक में अपना वो सूचर पास कर दिया, इसने नीडल के थ्रू कर दिया ना, नीडल ही पास कर दी उस लूप में से, और फिर ये अब नीडल को विड्रॉ करेगा. मैनी वेज ऑफ पुटिंग दिस टेक्निक थ्रू. अब आप देखें कि जब उसने अब टॉप लेफ्ट पे नीडल विड्रॉ कर ली तो लूप के अंदर वो सूचर चला गया. अब वो लूप खींच लेगा तो आपको इन दी एंड ये चीज़ मिल जाएगी अक्रॉस द टीयर, एंड देयर आफ्टर यू कैन पुल ये ऑन द लेफ्ट एंड देन फ्रॉम द इनसाइड. अब चाहे आप उसको वर्टिकल मैट्रेस करें, हॉरिजॉन्टल करें, डिपेंडिंग ऑन द टेक्निक और ऑन द टीयर पैटर्न दैट यू हैव, और बाद में आप उसको नॉट लगा दें. ये हुक से वो डाल रहा है, वो देखें लूप में सिंपल सूचर. सो मैनी वेज ऑफ डूइंग, एंड देन यू टाई और नॉट आउटसाइड द कैप्सूल. वो जो आपने ये वो मैंने ये है आपकी बाहर कैप्सूल पे सूचर नॉट्स टाई हो गए, विच आर कैप्चरिंग द anterior horn of the meniscus. They are across the tear and tied on the capsule under vision. It's a very good, efficient, small, low-cost technique to fix a meniscal tear across the anterior horn for either the medial meniscus or the lateral meniscus. Rehab उसकी जैसे सारा डिस्कस हो गया. इन द इंटरेस्ट ऑफ टाइम इसको स्किप कर देते हैं, क्योंकि rehab जैसे हमने रिपेयर की डिस्कस की, ग्रेजुअल वेट बेयरिंग over the next 12 weeks or so, and obviously return to activities after minimum 4 months, starting with a gradually small activity progressing to high demand activities. And as has been talked, neurovascular injury को इसमें इतनी ज़्यादा नहीं, क्योंकि आपने इंसिजन दे दिया. and posterior elements में lateral meniscus में peroneal nerve is the major problem, but this is not the case here. You make an incision, you make blunt dissection down to the capsule. The failure भी हो सकता है obviously if your selection or technique is poor and your suture orientation is not proper, and there is inadequate protection of the repair, especially during rehab, or there is concomitant instability which you are not addressing, but then patients can fall and break their suture. That has happened also. So back in 2011 we published our initial results, but this was for inside out technique of meniscal repair. Obviously that is another topic, but so the interest continues, and this again the presenter will tell you this inside out is also a very low cost technique. One of the major impediments in our working is finances. A lot of times treatment plan is dictated by patient's finances. So just to capture the question of PRP, so what we were discussing in the morning, this is a study with Meniscal to evaluate healing after repair with or without PRP, right? Double-blind parallel groups, placebo-controlled study. So this study showed intra-articular PRP injection following repair can be effective in reducing pain, improving knee function, slowing the rate of cartilage degeneration that accounts for earlier. So some evidence. And then this study in 2019, efficacy of PRP in arthroscopic repair for discoid lateral, regard to clinical evaluation, PRP group had similar effect in pain relief and functional improvement to non-PRP group. And then again this in meniscal healing for hyaluronic acid, we now have in Pakistan high density, high molecular weight hyaluronic acid, which is much more efficacious than the original Halgan injections. This study supported the use of HA in the conservative management of meniscal injuries and was clinically effective and enhanced meniscal healing as demonstrated by MRI measurements. So meniscal repair using the outside in technique. This prospective study of 25 patients with a follow-up of 24 weeks. Average IKDC evaluation was in which all patients were poor score pre-operatively. Clinical success was in terms of absence of pain, catching, locking and swelling, and is a negative McMurray, and occurred in 72% of cases. This was statistically significant. The post-operative IKDC at 24 with 81, and there were still, however, 7 patients with poor result. This was in 2015, a meta-analysis comparing meniscal repair with meniscectomy in the treatment of meniscal tears. The more meniscus, the better. And discussed this multiple times this morning, and I hope that concept is clear. Now, just a small video from the internet on how to do this technique. Again, I think easy for those who know how to do arthroscopy. Very easy technique to learn. The way diagnostic arthroscopy is performed, and here you see you are on the anterior horn of the medial meniscus, and there you are identifying a tear. Now the lateral meniscus probably. So now you are passing needles, passing suture, and one suture has been passed. Now you see the loop. In the loop, now through the loop, that's the loop. The grasper will pass this suture into the loop. Now this can be a suture loop also. You don't have to have sophisticated wire loops. ठीक है ना जी? So इन्होंने wire loop दिखाया है, but just for the battery ran out. But anyhow, the concept is clear that you loop, one suture is passed straight and then you pass a loop. Here the wire loop is shown, but you can have a suture loop which would just do the function, and you bring the something out. You can have multiple passes. You can use one suture, 2, 3, depending on the length of the piece. That's all this video had to show. Thank you. So we move to Dr. Kazan now, who will take us through inside out.
So to make my life easier, so I just made a 12-minute video which is going to demonstrate how we can do our inside out technique. So it will be on the mannequin, so it's more easier, and I can explain it better how we can do that.
If you see, as this is the medial spine. So if we assume it is a medial side and it is a lateral side, so what we are doing, we are just trying to repair the meniscus. So if I'm going to stand over here, so this is how my camera picture will be moving into lateral to be moving on this side, and the into medial will be a working camera to which my instrument will be moving over there. So first of all, let us see what the things are. So this, if you appreciate the steer that goes from the body and come to the anterior. I will not going to discuss about the anatomy. I will not going to discuss about the other aspect of this tear. I'm just going to go about the technique that we are using. Before starting this, how we do that, I just want you to see the different instruments. This is what is the acute fix instrument, which is known as a meniscus grasp. So
So over here, if you can see, this is a meniscus strap, a very handy instrument. So you want to, there's a 2 or 3 way you want to augment the vascularity of that area so that healing can take place. You can use this meniscus strap, otherwise with the multiple puncture into the meniscus with the elbow by any 10 cc needle, it can also do the same function. So this is one of the instruments, it's on the table so you can see it and feel it, how it's all about.
Always before repairing the meniscus, you want to have clean edges without any fibrosis. So that there will be bleeding edges which can help to healing of the meniscus. So a repair in the human body, it's not only just to go and just give some stitches. You have to create an environment where there's a repair also. So through this, you have to clean the edges. That will help us to have the bleeding edges, and later on the healing can take place. So we all know about.
So this we all know about the scope that we use to assess the meniscus. So this is another instrument also over there. So you have to feel it how the hook is and how you have to use it.
This is the whole of the set which has been provided by the Smith & Nephew equipment set is over here. So this different angulation for how we're going to insert the long needle for the inside out technique. If you can appreciate it, this thing, can you just focus the camera over here? So this instrument, if you see, they have 2 holes, but it has been linked with each other. So this has its own advantage. And if you see over here, the same thing. So this is being 2 holes through which our needle is going to go, and it has been linked with each other through this thing needed, so that our needle can go to the direction that we want. If you see, it has been curved. If I say for the left side, it upside down curve. This is, if you see, it is go curve go up. And if you see, this is also this curve go to the left. If you're going to move it, it can go to the right. So both sided can be used. So now the main implant which has been required. This is a long needle, or this is of Smith & Nephew. A different company is providing this. It's a long needle with the
The beauty of that implant that you can see, it is elastic. The elasticity is the main component of it, so that you can curve it to that instrument, which can go to the direction which you want. So this long needle is also available. You can just hopefully after that we're going to do a practice, and you can just work it on the station.
Sure, attach it to the end. If you can appreciate over here, this is how it's going to look like, and this how it's going to look like that. So here now what we were going to do. Now if what I have been told you, it is the medial side, is from the lateral side. My camera is from the anterior, the camera portal, and anteromedial is for the working portal. So, but as there, mostly this inside out technique is being used for the body meniscus tear. It is not being used for the posterior horn, because you know there is always a posterior and there is a neurovascular structure. So for that, inside out technique is being used, and Dr. Navi Juman is going to further elaborate how it is going to does this posterior one. And for outside in, it's go for the anterior horn. So these are the technique we should know where to apply and how we need to apply. So now what I am going to do, I am going to shift my camera to anterior medial portal. So my camera will be over here. This will be my working area.
So for standard starting, we always take an anterolateral as your camera portal and anteromedial which will be, but at the same time we should have start to skills ourselves to shift the camera. It can go here and to there. It's not standard always that anterolateral mean only camera. It can be shifted according to your accessibility to that area.
So now this is the instrument that I have told you, and these are the needle. So I am just going to push my instrument over here, and that's how it will going to go through it. So this will going to go inside, and this where my this instrument will have to hang on. So first of all, I am going to put the first of this this needle coming out through it. If you see, as it is going to come out, so you will going to bring into that position. So now that will going to remain the same. I'm going to tell you the advantage of this instrument, why it has been required. The other hole is through which we will going to put another needle into it. If you see, this is another for the meniscus to be together. We're going to bring the central part of the meniscus close to it. So this is the use of it. Why we use this thing, this instrument? One, to have precisely we're going to able to pass the suture where we want to have it, and we want to make sure the needle to come out from the later position. We don't want the needle to go and coming out from the posterior where it is a danger zone.
As I've told you, this needle is elastic. It's very hard to control it. If you want to have it close together, and that's being too close is very important because of tying a knot at the same time to the one hole. So you both have to be millimeter to close so that the knot will be easier for you.
So after that, we will going to apply a sliding knot. So this is basically the shoulder surgeon mostly using it, the sliding knot. You are going to tighten it, and it will going to go, this is how it's going to go. And we're going to tighten up on the inside, on the synovial area. So what else that we do to make sure to secure the knot? So this is a knot pusher that we always use it. We were going to push the knot pusher into it. We're going to tighten it. We're going to tighten it like that. It will going to help us to secure our knot. Once we're going to do that, that goes another knot also, and with the help of a knot pusher again, we are going to push it and secure it and tighten up. The knot pusher is mostly the shoulder guy who's using it, so we are using this. So this how the inside out technique is being used. So if you can focus it over here, So what my point over here, just to make it very important, once the needle is going to come out, it will be through the skin. So once the needle is there, and when you're going to pass another needle, so make sure just to increase the this from the second one, which the needle is come out, to extend the incision, and with the help of a hook, go inside through the skin and make sure the other stitches is coming to the same plane, so that it's able to going to have a very tightened knot. So just to summarize this, what we have done this meniscus repair through the inside out technique. And what we use long needles with the suture on it. And of course, this is also amazing. This Smith and Nephew has this long needles in which you can just put the sutures into it, and you can tighten up and you can use it multiple times. So this is what is inside the set. You can use it multiple times. But this is the disposable which is being used once time.
So this is also can be a cost effective because with that long needle with where you can tie a knot, and with the PDS 20 or 1 you can use this same needle multiple times, and you can it will definitely reduce your cost.
And these two needles we just use to pass from the inside out. If you're going to go from the medial, for the medial meniscus, your direction would be from the anterolateral. For the lateral, the direction will be from the anteromedial portal. So this is a very important instrument which is help you direct where you want to push your needle to go in which direction. Once it is over here, so you have to bring out the one plane, and then with the help of a sliding knot and knot pusher, you can tighten it up. Thank you.
That's it. Any question you have? You want to ask any questions?
How much skin is here?
Sorry?
How much skin is here?
So, less than 0.5 centimeter.
You are doing multiple things.
What because what I also told is both of the needle is coming very close to each other. The second needle you just extend it. Yeah.
You are doing multiple things. Long here.
So you can do it multiple, like every time you can have a single knot, as much you want. 2, 3, 4. It's for the body, basically you want to do it. So RAM kabhi kya main dikha दूँ outside in technique how to do it. This how we do it, basically the ramp repair, that's another very important topic. So we have talked about the ramp lesion. So what is the ramp? This is basically between the menisco-capsular area, that way. And most of the time when we arthroscopy this area, that's mostly it's been ignored because the accessibility toward that area is very less. So for us, for a young surgeon, it's like we have to make a habit, try to go to the posterior of the medial meniscus. That's from the anterolateral. When you go between the ACL and the condyle, make the knee slowly make the knee extend. So you're able to go posterior. Once you enter the posterior, that's you easily can see the meniscus junction and the capsular junction, and that's where the ramp is. So it is most of the common missed injury is ramp. Other option just to do the pie crusting is like something like you can do it like that. So all of the arthroscopy which I do, I always go posterior. That's easier. That we're going to also learn to how to do a posteromedial portal for the PCL even. That's how we can increase our skills. So I will go through it, okay, how the things are. So this with by going to the posterior to the between the ACL and the condyle. So this is what the ramp lesion is. If you see this is the meniscus and this is the capsule and this is whole of the area is tear. So now you have to make a portal, posteromedial portal with the help of a needle. You put it inside and then with the 11 blade, you make a good incision so that through which cannula can be passed. And that's how with the help of a hook that you are able to appreciate this tear, this synovial meniscal or this capsular tear, which is known as the ramp lesion. Now, putting the shaver, cleaning the area to make the environment better. This is the cleaning area. So lasso, this is another shoulder instrument that is being used. With the help of a lasso, you can repair it very cheap, but of course a very steep curve learning. To make it, you have to put this through the both ends, and it's same like how you do outside in technique is same that you have to bring it in with the help of a sliding knot, then you can able to repair it. So this is all about the sum of the way you can repair your ramp lesion. Thank you very much.
Anji, question? We have done with the theoretical part. Obviously, it has been long, but theory is much more important from the basis and your foundation of practical work. Practical
Now work will be distributed. We have 3 tables for Smith-Nephew, 3 for Arthritis. So 1 each for outside in, inside out, and all inside.
Fast fix flex meniscal repair system. Reach more, repair more. There is a 53% increase in the prevalence of osteoarthritis after meniscectomy. A study found that meniscectomy results in a 132-time increase in the rate of total knee replacement. About 7% of patients expect a meniscal repair. However, only about 15% actually receive a meniscal repair. 96% of meniscal repair patients return to pre-injury activity levels. At Smith & Nephew, we take every opportunity to repair more meniscal tears, helping patients to stay mobile and active longer. For more than 20 years, Smith & Nephew has been pioneering and consistently innovating meniscal repair. In 2021, we added our next generation Fast Fix meniscal repair system, the Fast Fix Flex. Smith & Nephew is accelerating the standard of care toward meniscal repair. With our all tears, all repairs, meniscal solutions portfolio, including the Fast Fix Flex meniscal repair system. Fast Fix Flex offers you the power to enhance accessibility, preserve anatomy, and increase reliability. Flex has curved and reverse curved wheel options. The built-in protective wheel strap may eliminate the need for a camera. Simply press the depth penetration button to move forward and cover the needle before inserting in the joint. The Flex bend tool enables guided needle modifications. Curve goes from a 24-degree angle up to 35 degrees. Reverse curve from -12 up to -22 degrees. Flex's shaft can also be bent using the bend tool to create a single bend or compound to achieve greater reach. Flex's curve and reverse curve shaft can be bent up to 80 degrees. Fast Fix Flex enables all zone, all inside meniscal. The Insertion Tightrope tube is the most evolution adjustable portable suspensory procedure. The Tightrope tube implants a proprietary novelty 5-point locking mechanism, resists cyclic displacement, and offers excellent tensile strength. The new Flex Tape Tightrope offers improved ground interface with ample characteristics. The Tightrope tube implants engineered to precise gratification and the ability to incrementally retension the muscle after cord fixation. The new proprietary 5-point locking design of the Tightrope tube button resists cyclic displacement. Tightrope tube implant is available in a variety of configurations to accommodate various grafting options and technique preferences.